So, welcome everyone who's managed to find us via Craig's page. Apologies for that. To episode 73, PodChatLive episode 73, and we're delighted to be joined by the panel that you see in front of you, who we'll get on to introducing in due course. But this is a bit of a special one because a lot of our episodes are us chatting, academics perhaps chatting, or people, and this one is for really genuinely, truly for everyone. We've got a scenario here where, given the current global situation, there's been a scaling back of a lot of services, and there's a very real risk that could result in an increase in lower limb amputations. So when we were speaking to Martin Fox, who we're well known to everyone on the panel here as our vascular specialist podiatrist, it was really important that we got the message out there to everyone of what the big risks for immediate amputation are, and how everyone gets comfortable assessing these and triaging these. So we want people to leave this session with greater comfort, greater confidence in identifying, assessing, triaging the big risk factors for amputation. The guys at Foot Diabetes UK have generated a brilliant pathway, which you can probably see as Craig's green screen backdrop. Don't worry, we will be linking to that. We will be zooming in on it as we go through the chat. So in no particular order, let me introduce the panel, and I want to say thank you to all of them for their time. I've put my glasses on to feel more intelligent in this company. Unbeknownst to me, a couple of them are actually wearing pajama bottoms, so I probably hadn't bothered. But in no particular order, we've got Mike Edmonds, who is a consultant physician. As we've already said, we've got Martin Fox, our vascular specialist podiatrist, who'll be known to everyone. Paul Chadwick, College of Podiatry Clinical Director. Naz Nasir Ahmed, Consultant Vascular Surgeon, set the stage alight on our annual conference as well last time. I'm sure people recognise him from there. And Emma McConaughey, I hope I haven't butchered that, Emma. Apologies if I have. Who is an incredibly experienced private practitioner, well known to people as a College of Podiatry sort of representative, and helps most of us with queries on the internet almost daily. And she's going to bring things together for us to, at the end, be our representative as all of us as private practitioners, who, myself very much included, are perhaps less familiar, and we don't see the at-risk on a more daily basis. So the two biggest risk factors for immediate amputation, severe infection and ischemia. We're going to sort of take this episode forward with all of these specialists here sort of talking us through the pathway, and they've divvied it up into their areas. And I think we'll start off talking about infection, if we may, and we're going to have Paul and Mike take us through infection. And for anyone listening, if you have any questions as you go along, ping them into the comments. I'll scribble them down, and we'll have a little panel Q&A at the end. But Paul and Mike, if you don't mind sort of kicking us off, talking us through infection and how we get comfortable and confident sort of assessing and triaging.
Yeah, thanks, Ian, for that. I'm happy to pick that up in the first instance. Then I'll probably pass us over to Mike for the severe infection and let him describe sepsis for us. So infection, I want to make it clear, is a clinical diagnosis. So we need to think about how we diagnose that as a clinical. It's not based on swabs. It's based on what you see in front of you. So we think about infection based on, there's 5 cardinal signs of inflammation. So that's heat, redness, pain, swelling, and discharge. If you have 2 of those 5, and they can exclude other causes of inflammation. So if someone's fell down and stubbed a toe, or got a burn, or some reason why they've got inflammation, then potentially that might be a cause for inflammation. So gout is another example, or these other causes of inflammation. But if they've got heat, redness, pain, swelling, or discharge, 2 of those 5, in the presence of a wound, we should start making a clinical diagnosis. And what's really key about this clinical diagnosis, is that we can put that into a severity, and the background that you can see behind Craig there, where we're talking about this severity status. It's really key that we start as practitioners on the front line thinking about how we manage the lower ends of infection. So the no infection, the mild infection, and some moderate infection, depending on our skills and capabilities. So we think about what no infection is. It's a wound that's got no heat, no redness, no pain, no swelling, and no discharge. I'm going to say that many times, hopefully through the next few minutes, so people take that message across. And then what really the key one is these mild infections. So these mild infections are where there's redness, less than 2 centimeters of redness around the wound. or where the wound is superficial. In other words, it doesn't probe to bone, there's no tendon visible, it's a superficial wound. And that we would class as a mild infection that can really be managed and assessed in community and in the front face, in the frontline clinical space. We then move up to a moderate infection, and that's where it becomes a little bit more difficult and where that should be managed. It certainly needs some support from the MDT, it certainly needs some guidance from an MDT, but a moderate infection is where there's a deeper wound. So we've got a wound that maybe probes to bone, or there's an abscess present, or where there's there's extending redness more than 2 centimeters. So we've got this differential there. Then that's the really key differential in terms of mild to moderate and how we pick that up and how we manage that, which we can come back to later once we've discussed severe. I'll pass over to Mike now to talk you through what severe infection looks like and how that presents.
Okay, thanks, Paul. It's very important in these days to identify infection that may be limb-threatening or sepsis which may be life-threatening. So what threatens the limb? The limb can be threatened by an ulcer extending down to bone with infection tracking through the surrounding tissues. And the limb may also be threatened by a rapidly spreading cellulitis, indicated with the classical signs as Paul has just described: redness, swelling, heat, onset pain, and associated with discharge of pus. But it's a rapidly spreading cellulitis. And look for other signs, such as, say, crepitus in the skin, indicating gas in the tissues. And look also for patches of black discoloration or wet gangrene. You know, this is necrosis caused by infection and is limb threatening. The whole issue here with regarding severe infection is that you've got to ask the question, does this patient need surgery, need surgical drainage? Because that's really the crucial point for making the diagnosis and getting the patient into hospital. Also note that the presence of an infected ulcer in a critically ischemic limb can also be serious and life-threatening. So if you notice any of those in your practice and you feel that the limb is threatened, then you've got to make an urgent referral according to your local protocol pathway. And it's really got to be done that day. If there's a degree of ischemia to the vascular department, you may be referring to the medics or to the orthopods or to the podiatric surgeons. But whatever your local protocol pathway is, you've got to get that in that day. Now, let's go to sepsis. An infected ulcer may be associated with sepsis, which, as we know, can be life-threatening. Now, how do you recognize that? Well, again, you've got to make it the diagnosis on a clinical grounds. The patient may just look unwell. He's just not his usual or her usual self. May have flu-like symptoms, may be a little confused or drowsy, or unresponsive in severe circumstances. You know, that makes you think there's something going on here, maybe sepsis. When you look at the patient, they may have a high pulse rate, over 90 beats per minute, or they may be low, below 50. If you count the breathing rate, the respiration rate, it can be over 20 breaths per minute. Anything over 20 breaths per minute is a warning sign, or it could be below 11. Now, there are 2 points to make at this stage. I've talked about the symptoms and signs of sepsis, but they may be diminished or absent in diabetes. So you really got to be a good detective, and if you pick up a modicum of these signs, you've got to think that this could be sepsis. And the other point I want to stress is that these symptoms and signs of sepsis may be caused by COVID-19 itself. So please be aware in these days that if you've got an ill patient, he may have a foot problem, but it may be COVID-19 itself. Whatever the cause of sepsis, you've got to get an immediate referral to the local hospital emergency department. I think that will be the protocol pathway for most people. Get to the ED emergency department, and that department can then sort out, A, confirm whether this really is sepsis, and B, sort out the cause of this, whether it's COVID or a foot problem. So the take-home message from this part is you've got to diagnose infection and sepsis, severe infection, promptly, and thereby in these days you can then save a life and a limb. So I think that, thank you, I think that's the initial things I would like to say about severe infection.
Actually, can I just ask a question, Mike? Have you seen any infections recently, I mean diabetic foot infections in people with COVID-19?
Yes.
You have, okay.
Yeah. And actually one patient came with a minor foot problem, but he just didn't seem himself. And you know, Craig, with this COVID, there's the classical cough, there's the classical fever, but there's also the atypical signs, and some people just feel washed out. You know, they're just not themselves. And we did the test, and you know, it came back positive. So okay. I think you've got to have a wide sort of spectrum of diagnosis for this condition.
Perfect. Anything else, Paul, that you need to say about infection before we ask Martin and Naz to take us through some ischemic comments?
No, I'm very happy with that. I think we've gone through the severity scale. We just need to remember those 5 cardinal signs and symptoms of inflammation. In the presence of a wound, start to suspect infection. Really important that you categorise into that mild, moderate or severe. That really drives your referral processes. So yeah, I'm happy to pass over to Naz and Mike and Martin rather.
Great. I've just had a quick question in actually, which I might fire back to you, Paul, just while we're on the topic. It's not specifically to you, but it's a comment about how the current sort of impact of COVID-19 is making a lot of us work more virtually. So, you know, through digital online sort of consultations. The sort of, I guess, assessing or triaging of these cardinal signs completely viable over virtual consultations?
Yeah, I mean, in fact, Naz did a perfect example last week where he was seeing a patient in a virtually with a podiatrist in a person's home, and he was comparing the results of what the pictures were that the podiatrist was sending through on I think it was like a WhatsApp type system. Naz, if you can correct me if I'm wrong. And really so as long as you've got reasonable pixelated cameras, and most of the common smartphones have really good cameras these days, you can pick up the cardinal signs and symptoms virtually. If you go to the American guidelines, which are on the links, which we'll give out later, they all feet on deck. They're very much working towards consultations for these types of situations, and they're having the conversations about when somebody's actually been on antibiotics, using virtual consultations to stop the antibiotics after maybe a mild infection. So I think that the potential there for using this virtual technology much more, and probably much more in the future as well after the COVID's finished.
Yeah. And add to that, even today, a patient's wife took a picture of her husband's foot and sent it into the clinic, you know, and that sort of set off the process of diagnosis of infection and the appropriate pathway.
Great. Actually, Michael, I've just had a comment asking you if you could tilt your camera a tiny bit downwards, because as beautiful as your eyes are, they're the only thing that some people can see, and they can't see.
Yep.
That's great, Mike.
Yeah. It just seems such a shame to waste, you know, most handsome man here, some would argue. So it just seems a shame to waste it. Martin, Naz.
Ian.
Yeah, sorry.
Could I just ask there on the theme of infection, because it's not an area for me I work comfortably with chronic peripheral arterial disease and cardiovascular issues and smoking cessation, motivational interviewing. But infection is something that I don't tend to manage daily in my traditional role. But I'm going to be seeing a lot more of it, I think, as I work to support nurses and high-risk foot teams. managing infection that isn't sepsis, has Paul got any tips on how we, as clinicians who are not that au fait with pushing for antibiotics, could be getting a little bit more confident in that sort of mild to moderate management, and making sure that GPs in particular were working with them in a timely way to get the most appropriate first line antibiotics? Have you got any thoughts on that, Paul, how we might get more comfortable with that theme?
I think it's key that as a practitioner in an area, you find out your local antibiotic guideline. Antibiotic guidelines change from area to area depending on resistance patterns and different prescribing routes. So commonly what you would be looking for would be in a new antibiotic naive patient would be something that's effective against gram-positive cocci without getting too complicated. But in each area, the antibiotic of choice against that infection will be different. So you need to go find out on your local hospital website. There is usually an antibiotic guideline for all common infections, not just foot infections, but they will be there. Get used to them, and then when you're speaking to your GP or your prescriber, you can have confidence that you're choosing the right antibiotic. Say, this is the patient, they're presenting with this mild infection, the first line in this area commonly would be flucloxacillin, for example. And I think that's really getting to know your local guideline around antibiotic prescribing is key. I don't know if Mike wants to add anything to that.
Yeah, I agree. One's got to be aware of antibiotic stewardship, but I think anybody phoning up has got to give over the issue that a patient may be in trouble with early infection, and the sooner we treat that infection, the greater the chance we have of preventing that person going into a severe infection and then needing a hospital admission and needing a precious bed. So while we've got to be aware of antibiotic stewardness, I think we've got to be really sharp in treating the early infection, so that, because the whole point of this is to save the hospital beds, which are at a premium at the moment. So only the very few foot problems that really need hospital admission get in, and we save the rest of the beds for our hospitals are now being turned into COVID treatment centers, basically. Hundreds of people, hundreds of patients in the hospital. So I think people, I think, Martin, you were, the gist of your question was, how confident should people be in phoning up for antibiotics? And I think they should be really confident.
Thank you.
I just want to just mention something that Mike Green commented on. And the reason I want to mention it is Mike Green may not know this. He's the reason I'm a podiatrist. Slightly off topic there. But yeah, he may not know that himself. But he just said, good guide for antibiotics download is the Micro Guide app. You can download the guidance for your local trust. And off the back of that, a few people have mentioned in this current situation, there's a reasonable good argument that the independent prescribers amongst us and the POMS kind of podiatrists have a fairly strong role to play. If you've got anything to add to that, Paul.
Yeah, it's really key. We've been looking at the sort of redeployment of AHPs currently, and one of the key things that stands out is the fact that podiatrists have access to many different medications through many different routes. We're independent prescribers, supplementary prescribers, POM-A, POM-S, and use PGDs. And when you look at the box ticking exercise in terms of who does what, we're the one that stands out. So we've got a real key role in this in terms of the access to medicines that we have that we probably underutilise as a profession, but actually we could probably use a lot more, particularly in this crisis.
Yeah.
Time is
tissue.
Yes,
I think time is tissue, and the earlier you get in with antibiotics with infection, the quicker there'll be the resolution, and there won't be any need for this, admission as such.
Sorry, Emma, go on.
Yeah, I was just going to say, from an independent practice point of view, I have got POM-S, but I only have a very small, limited amount of antibiotics in the clinic, and my supply lines are drying up as well. So whereas my clinical team would normally be able to go to the cabinet and get antibiotics, right now we're going to have to go back to looking to contact our local GPs. So there might be a little bit of a change for some practices in that respect as well, purely because we can't get the supplies right now.
Great. We'll just very briefly, although I'm sure we'll come back to, just put opinions infection for now, and we'll start talking ischemia if we may. So Martin and Naz, if you don't mind talking us through that side of the pathway, so to speak.
Okay, if I come in first, Naz, is that okay with you?
Yeah, absolutely, mate. Yeah.
So just to sort of re-emphasise the point of this guidance from FUK, it's for all high-risk lower limbs and people presenting with that. So not just people with diabetes, we're also looking at people with other long-term conditions who may have high-risk lower limbs, primarily because of vascular disease, but also things like connective tissue disorders, foot deformity and neuropathy from a non-diabetes cause. So when you're looking at the lower limb, I think certainly in my experience, podiatrists and nurses are a little bit nervous sometimes about making the call on peripheral arterial disease or critical ischemia. And we really want to simplify here what we'd be hoping the clinician, any lower limb clinician will be doing. If they're checking out a lower limb with a new problem, primarily new pain or a wound that appears to be going the wrong way, that they can, in a structured way, just have a think about, is there any severe ischemia in that foot or leg? And if so, how are they determining that? And you might see our critical limb ischemia box there as just a few bullets. But if you use it sequentially as a clinician, and you start by feeling for the foot pulses to see if they're easily palpable or not, and then if you've got your Doppler, having a quick listen with that to see whether they are dull monophasic or whether they're nice clear bi or triphasic pulses, you're starting to build up the picture. And then if you're suspecting severe ischemia because of the presenting pain in the foot, which may be constant, severe and unremitting for at least 2 weeks and isn't going away with usual pain management such as paracetamol use, then that pain in the presence of non-palpable and monophasic pulses, or if you want to simplify it further, weak and whooshy pulses, is likely to be vascular related until proven otherwise, unless of course there's a coexisting infection, in which case it could be pain due to that. So to sort of put that down into that simple quick check, you've palpated the pulses, you've had a quick listen, you may have raised the foot up high to see whether it goes pale, the Berger's test, and then if it does go pale within 30 seconds, sort of deathly pale on the plantar surface, and then you put the foot back down onto the floor, it would usually go a sort of deep red in response to the ischemia. So you've got that pale white up above, deep red down below, pulseless foot, and monophasic at best on Doppler. You're already thinking this is probably critical ischemia. And then if you can take a simple, basic systolic blood pressure, either using Doppler and Svig on the ankle to see if that pressure is less than 50 mils of mercury, because less than 50 mils of mercury is always bad. If it's higher than that, it doesn't mean it's always good, but less than 50 is always bad. Or if you've got the beautiful new toe pressure kits, you can be putting that around the big toe, putting your PPG sensor onto the toe end and taking a blood pressure of the toe. And again, if you're able to do that with one of your team, or you've got the kit available, to get a pressure less than 30 mils of mercury is, again, bad news for the foot. And it's likely to be confirming that clinical diagnosis of critical ischemia. Now, critical ischemia is usually quite chronic. There are some big clues as to why it's there, usually in the history of the patient who's presented to you with a barrage of cardiovascular risk events or factors such as diabetes, hypertension, there may be some ischemic heart disease, hyperlipidemia, often a strong history of smoking, still too sadly, maybe still smoking. And it's sort of building that cardiovascular picture onto the clinical picture you've got in the limb there. So if you've got those 3 or 4 signs of critical ischemia, you're then weighing up whether that limb has also got coexisting infection, in which case we've got a really bad situation, or whether it's a stable chronic critical ischemia, and maybe, even though ideally you'd refer that patient on to NAS, usually, it might be in this situation you're taking some telephone triage advice to manage the patient at home with the GP, the district nurse, and the podiatrist to control pain and try and keep wounds at bay. So as a first stab, that'd be my thoughts about how we might assess for and think about critical ischemia. And I suppose at this point, I'm really best handing over to Naz.
Cheers, Martin. people are often scared of vascular, and they don't. Sometimes people feel afraid of speaking to a vascular surgeon, either a registrar or a vascular consultant. Often for very good reason, because traditionally we're not very friendly, and just want to try and reassure people that we are actually quite nice. You know, times are changing, and we are actually quite nice nowadays. And many vascular surgeons work really closely with podiatrists. I'm really lucky working with Paul and Martin over the last few years, and all the guys in Salford and in Manchester. And they've really worked hard to upskill themselves and refer the patients to me at the right time. And what is absolutely crucial for me is that the patients are assessed in the community and then referred to me, as I say, at the right time. And Martin's absolutely right in that the way you diagnose an ischemic limb is either on the history or on your examination. So from the history, it's about getting rest pain. And I only really ask one question when it comes to rest pain, and that is to a patient, I'll say, do you have to hang your leg out of the bed at night? And if they have to do that, that is generally rest pain. Or they often sleep in a chair, and it happens all the time, every night. It's not just now and again, once or twice a week. It's all the time. There is a slight proviso with that, in that with diabetes, patients don't often have the same sort of pain response. You just need to be slightly careful about that. So the first thing is in the history, do they have that rest pain, which is a pain all the time? And then, as Martin said, it's about looking at the foot and having that index of suspicion. And then it's about doing the systolic pressure on the toe now. And as Martin knows, I'm a big fan of toe pressures. And allied to that is the ankle pressure as well. So once you've got those, you've got the basic, the alarm bell should start ringing. And there's when I was a young surgeon, just not too long ago, one of my trainers said a lesson which I've never forgotten, which is, if it's not right, it's wrong. And if it's wrong, it's your duty to make it right. And the only thing you may have to do is pick up the phone and speak to a vascular surgeon, and never, ever be afraid of that. You know, sometimes people think that the vascular surgeon might think I'm a bit of an idiot. We always do, so don't worry about that, all right? So the key thing is pick up the phone and just speak to us, and just be completely honest and say, listen, I'm not happy. I don't know. You're the experts. Can I bow down to your amazing knowledge and refer this patient to you? A bit of flattery helps enormously, and we love that kind of stuff. So if you're scared of a vascular surgeon, just be nice to us, just be deferential, and we will take your consultation without a shadow of a doubt. So the first thing is to get that right. Then what we do from that is we will then make a decision as to what we do with that. And there's two things we do. We then order a further investigation, either a duplex scan if the community podiatrists don't do that, or we then do some kind of angiogram, either a CT, an MR, or a digital subtraction angiogram. And then we will treat in one of two ways, either with an angioplasty and stent, or with a bypass. And just to pick up what Mike said earlier on, in this current COVID crisis, what we are generally tending to do is treat patients endovascularly, so either an angioplasty or a stent, because that is a day case procedure done under a local anesthetic, and the patient will go in and out the same day. A bypass we try to avoid in this day, because that involves a general anesthetic, which takes up an anesthetist, a ventilator, and a prolonged hospital stay. And if a patient has got COVID and they have a bypass, the mortality rate is really quite high, up to 20% in some of the studies which are coming out now. So from the community point of view, as long as you've assessed it, and through your assessment, either from the history or from your investigations that you've done, either toe pressure or history, and you're not happy, just pick up the phone. The key thing that I want to get across today is that vascular is still open. The hospital isn't closed. Vascular surgery isn't shut off to you. Speak to us. Our clinics and stuff and our routine stuff, it has been cancelled. But many of us now have daily hot clinics, and the community MDT foot clinics are still open. They're one of the precious services that are staying open. So if you are worried at all and it's not right, just phone us and we'll help you as much as we can.
Now, we've also put into the box there, they're quite rare, but for us anyway, but it does occur, acute limb ischemia. Could you just quickly run through that as regards to how it usually presents out of the blue?
Cool, yeah. So, so there's essentially two types of ischemia. There's acute limb ischemia and chronic limb ischemia. And as Martin said, chronic is basically, it needs to be going on for at least 2 weeks before to be given that title of chronic. And that is a spectrum of disease. Acute limb ischemia is completely different. And what happens is you have essentially a normal limb. Often you have the pulses which are palpable, and then something happens to suddenly stop the blood supply to that limb. And what you'll generally find is that the foot goes cold, it goes white. You often then start to lose movement and sensation, and it's a sudden thing. The patient can often time it to when it actually started, and that is a vascular emergency, and that patient needs to be seen the same day. From a vascular point of view, if you see that, the way you can tell whether it's acute or chronic is essentially just examine the other limb. If on the other limb you've got a full set of pulses and it looks normal, and the limb that's a problem has no pulses and it's something new and it looks white, that is acute limb ischemia, and that needs to come to us straight away. When you refer to us as a vascular surgeon, we only need to know 2 things about that acute limb ischemia, and that is there sensation and is there movement? If you have sensation and movement, you've got time to try and save that leg. The first thing that tends to go is sensation. The leg becomes a bit numb. And then when it gets more severe, or it's been going for a long time, you start to lose movement. And these are signs that things are getting quite bad. So if you see essentially a normal limb and then it suddenly goes white, suddenly goes cold, particularly if you start to lose movement and sensation, that is an emergency, and that needs to come to us straight away.
Thank you.
Okay.
Great. On the note of you being, vascular, being open, Naz, there was a comment by someone in London just asking if you've got any recommendations for a good vascular surgeon there.
There's loads of good people down there. It depends what you want, whether it's a lower limb stuff or whether it's some other thing. I mean, when I was training, I went down to Mike's unit and spoke with Hisham, and spent a day with Hisham, and I learned how to do pedal bypasses from him. So I would certainly recommend the team down in Kings, which Mike leads on. So that for me is a go-to team for lower limb stuff. If you're further down south in Croydon, you've got Stella Vig. So those are the sort of the main names that I know down in London.
Actually, Nassar, just the comment you made about vascular surgeons being quite approachable and that kind of stuff. We've actually had a comment here that's got a lot of thumbs up while you've been talking. And it's from Leanne, and I'm presuming she's a vascular nurse, and she said,
"Oh, Leanne Atkins."
or she's actually said, "Or if you prefer to speak to a vascular nurse, we're always approachable."
Leanne is fantastic, absolutely, yeah.
Actually, Naz, when you're saying that vascular surgeons are very open and happy to be phoned.
Well, I said it's changing, and we're becoming more happy and more open.
Well, more happy, personal, private, whichever one you want to go with. But what about yourself in independent practice? And same with Ian. Are we allowed to call you up?
Oh God, yeah.
I've never felt that's the case in Central Scotland.
If you are worried about a patient in the community and you think that this needs a vascular surgeon, just because you're in the private sector doesn't mean that you're excluded from that. The patient is still a patient, and they still have access to the NHS. And if there is an emergency, that needs to go to the NHS, and they need to come to us. So there should not be at all any hesitation. Just because you're in the private sector, you cannot refer to the NHS. No, I would say absolutely, it's you are the patient's advocate, and you need to speak to us if you are worried about that patient.
If I can just come in there again, Emma, it's a good point you make. That I think a lot of clinicians don't feel they can contact vascular teams directly now, not even for emergencies, because we're just not used to doing it. So many people would go through the GP as a port of access, and I think if clinicians feel they have to do that they must do that with the degree of urgency from the pathway, from the guidance that we've given there. So that GP is not going to delay that call another day or another week, particularly if it's an acute limb ischemia. But of course, one way around that is to ring the GP and inform them that you're going to contact the vascular team, and just touch base with the GP first. That, and with these clinical criteria that you've seen in their patient, are they happy for you to ring through to the registrar? And in my experience, GPs are usually more than happy for a clinician who's on their game with a patient, knows that patient to some degree, to make that call on their behalf and move it on. But they do want to know sometimes where it's happened, because it's their patient. So I think, Emma, it's one of those things where you might be, that first phone call, I remember my first phone call to a vascular surgeon, I was scared. I was nervous. I thought I was going to get told off. But I structured it. I looked at the 3 or 4 things I wanted to say on the phone. I wrote them down first. I made the call to the registrar, and it went amazingly well, because I had a simple structure to the call, and the registrar wanted to know certain things, and I could give them that information. So I think it's just having a go using the principles of the pathway for the first 2 or 3 times until you feel more comfortable with it, but certainly possibly involving the GP, at least retrospectively.
So extra bonus point question for you both. What happens if it's a weekend? Because us in private practice, we work weekends sometimes. And my last critical limb, I will say, I'm pretty much general. I don't often see a lot of the high risk stuff. My other colleagues do, but I don't. And it was a Saturday at 4:30 p.m. and I had a critical limb presented in a paraplegic, no less, which was fun.
Yeah, I mean, the key point, vascular is a 24-hour service, and there is somebody on call. We do whole weekends, so I'm on for 60 hours straight when I do a weekend.
God, that takes me back to the early days of private practice.
And most vascular stuff, it's an emergency service. There's very few things which are elective anymore. Like you got carotids, aneurysms, lower limb stuff. They're all quite urgent, so it's quite an urgent service. Just to pick up what Martin said, what does help enormously when you speak to vascular is to understand why you're calling us. What is a question that you have that you want us to answer? And that question is either you want information, or you want to get a second opinion, or you want the patient admitted. So as long as you've got it clear in your head why you are calling us, and you've got a coherent story that leads to that, I think a lot of the reasons why vascular surgeons sometimes get upset is they can get referrals which aren't well thought through, and there isn't really some thinking behind what the actual question is. But as Martin demonstrated, he went through what he wanted to say. He got his diagnosis. He got an idea of what the question was. And when you're presented with a structure in that way, and you've got your examination findings, vascular surgeon, we really like that.
I say the whole point of this pathway is to help people pick up limb-threatening conditions. So you're very well then justified if you think that you have a limb-threatening condition, then you are totally justified in speaking, either if it's infection, it may be a different person, but if it's ischemia, to the vascular surgeon. And one advantage of the centralization issue is that there is a vascular reg on call 24/7 in the hubs to take these calls. So I don't think anybody should feel intimidated about making a call.
Excellent.
After all, vascular surgeons are only human, aren't they?
It's easy to feel quite out the loop when you don't work in the
You say
NHS.
that, Mike. I'm not sure we are. I think we're slightly better than that sometimes, but that's just us.
I know you do. I know you do that.
I think just to emphasise the point that Martin and Naz have made, and Mike's made, it's really key about the information you give when you're referring to a GP. Quote the guidance, quote the things that we're talking about in terms of the criteria that we're going to use to make these diagnoses. I think it's key. If you use ischemia, for example, whenever we're doing lectures on the foot and diabetes module or similar things, people still ask, what about hairs present? What about thickness of toenails? What about this? And I think it's key that we give the information that's on the guideline, because that's what the vascular surgeons will make their decisions on. In the same way with infection, you know, you need to say that they've got 2 centimeters of redness, it probes to bone. So these kinds of simple information that were within this pathway will help guide the referral and the access to medications and the appropriate vascular surgeon or diabetes consultant.
Sure. I think you start off by saying, I've got a limb-threatened situation in my clinic because of A, B, C, D, E, and I'd like you to take a look at him in the clinic. You know, I don't think anybody can refuse that.
No.
And it wouldn't matter if we don't have a sphygmomanometer in the clinic, so we've not been able to do the toe pressures.
No, I mean critical ischemia really is a clinical diagnosis, isn't it? As Nash and Martin has just said. You know, if the poor guy can't sleep at night and he has to put his foot over the bed, and you know, that's the diagnosis, and you just send them in.
Leanne's popped a question up actually, asking if we could briefly discuss when not to refer, because she feels this is just as important. Even in the COVID crisis, she's getting referrals from clinicians due to absent pulses without rest pain or ulceration.
It's a good point, Ian, and thank you for that, Leanne. The non-limb threatening problems box is perhaps the most large number of patients we will see out there in the community or in hospitals, and it's really important that the clinicians are seeing that as a separate set of clinical indicators that are important, but are not immediately limb threatening. I think, Paul, you were going to pick up on this and maybe just sort of skim through the themes there about when not to refer urgently to the vascular.
If you do, after this webinar, hopefully have a look at the guideline in detail, but we talk about superficial leg ulcers that are showing signs of healing or evidence of healing. So this, well, that's quite nice. Thanks, Craig. So, you know, we think about things where the ulcer size is reducing. So we have the classic one for DFU, where it's reduced by 50% within a 4-week period, as a good indicator. So measure your wounds on a regular basis. If the wound's becoming shallower, there's less depth, if there's less exudate, all these kind of things would indicate that the patient is potentially wound is healing, and that doesn't need to be referred on to a hospital service. Asymptomatic PAD or intermittent claudication only is another criteria. So a patient who is walking, complaining of claudication with some absent foot pulses, they don't need to be referring at this particular moment in time. You need to think about assessing them effectively, getting them on best medical therapy. I'm sure Martin will pick me up on anything that I miss in this, but smoking cessation, exercise therapy. If they have hypertension, then we need to manage their blood pressure. If they've got high cholesterol, then we'd need to manage, you would think about statins. And then there's issues about antiplatelets and when they should be added in as well. And then we look at, again, similar things like mild foot or leg infections, which is how we started the conversation in the evening, in terms of these wounds that are superficial, that have got less than 2 centimeters of redness, which have got no depth to them, the patient's systemically well, there's no evidence of sepsis, that we can manage these effectively in the community with the support of our high-risk teams if we need to, or we can have conversations with the MDT, but equally it's key that we manage these patients as much as possible away from the hospital setting in this day and age. And crucially, the one thing we haven't touched on yet is acute Charcot, and I think and this is a neuropathy condition that we most associate most commonly with diabetes, but it's related to neuropathy. And we need to think about when we see these active Charcots, when it's hot and red and swollen, when there's no wound present, when you can exclude infection. And if you suspect a Charcot, we should be offloading these patients urgently. And again, we have to think differently in today's environment, that potentially casting potentially might not be the obvious solution. Might need to look at other methods of offloading, such as a boot or a crow walker, as we're having difficulties with aerosol generating from the castors, for example. So, but the key message is that we need to be offloading these acute Charcots as they're picked up, whether that's in community or in the hospital. So the hot, red, swollen foot with non-wounds, where with the neuropathic foot, we need to start thinking about Charcot. And I'm sure Mike would like to come in on the Charcot management, as it's another passion of his.
No, well, I agree with you, Paul. I think there's perhaps the pendulum swinging to the removable cast rather than the total contact non-removable cast. Simply so that we don't have to ask the patient to come up to the clinic relatively frequently for removal of that cast. It may not be ideal, but I think a removable cast is preferable in these situations, and it can avoid the patient coming up and being treated for almost the whole duration in the community, with perhaps surveillance by, say, a virtual communication, either with the patient themselves directly or with the community. So I think that's perhaps the one slight change of emphasis in these COVID times.
One thing, Mike, that I sort of read this week on Twitter from a clinician who sees quite a bit of wounds and Charcot was that because of the enforced lockdown, many people are actually naturally more offloading their feet, and to some degree wounds are healing, and Charcot are possibly being stabilised by people just being basically confined to barracks for a few weeks, and that may be one small positive in this picture.
No, absolutely, Martin. Yeah, we're seeing that, and I think Alberto Piaggesi, in his lecture with DFOT, also has noticed that. So certainly that those two conditions. So the ulcer, the uncomplicated ulcer, will respond, I think, to the less activity, as will the Charcot. Just to follow up Paul's point, I think there's this grey area of the moderate infection where you can sort of see the patient quite frequently in the foot clinic and do quite a bit of debridement. You may not sort of get it all done the first time, but at least to save an admission. And if you can back that up with community antibiotics, you can save quite a lot of admissions, and it's really only the horrendous infection which needs drainage that night, which will need to go into the hospital. So I think that the foot clinic can take on quite a lot of these moderate infections.
I think in reality, Mike, there'll be a lot of district nurse, community nurse, tissue viability, leg ulcer nurse teams that are working with podiatry services over the coming weeks a bit more closely, and they will be bearing the brunt of a lot of the chronic lower limb wounds and the management of that. And again, there may be some good partnerships forming there, where having to work together means that the management of such chronic lower limb wounds may be getting the benefits of both skill sets. So again, we might see some positives come from this in the management of wound and infection that's mild to moderate.
Yeah, and the MDFT setting up once a week the facility for a virtual clinic or a virtual discussion, so that these healthcare professionals, if they just want some encouragement and confidence, they can take a photo and discuss that with the MDFT, say once weekly. So I think that is also a support for the community nurses and podiatrists.
Yeah, I mean, just to follow on from that, Mike, in our local clinic, we've started a high risk foot WhatsApp group, and on WhatsApp you can have a 4 people on at the same time in a live video call. So what we've done is do virtual consultations just through that. And in these sort of current circumstances, we've been given the go-ahead to do stuff like that. It's something which we wanted to do for a long time, but we've just gone ahead and done it. And you can get, I mean, I've spoken to patients, reviewed wounds, spoken to the podiatrists and the nurses in the patient's home and given advice, and as well as having all the other specialists there as well. So it's a real opportunity to try new things.
Yeah. Yeah, we have the same. As we have I think it's a Pando clinic as well. Also, I think it's actually showing, in a paradoxical way, that some people in the community, some district nurses or podiatrists, they're not struggling, but they want some advice, and they've in the previous past have found it difficult to get that advice because it's one channel or this channel. But now with this sort of telemedicine almost being forced upon us, I think these people in community who are really very compassionate and want to do the best for their patients can actually get advice, more direct advice than they could previously.
Mike, just one point. We're getting a wonderful view of your forehead again.
Okay, is that better?
Oh, that's better.
Yeah. Okay.
It's a very lovely forehead.
Beautiful. Craig, we've had a few people asking, I know we're going to post a link to it afterwards, but could we just do a full screen of the pathway and perhaps get, while we've got the panel here, get them to give us a bit of a real-time talk. I got the impression when Martin first sent me this, that this was aimed at being printed off, laminated, putting up somewhere for immediate sort of reference. Could you guys talk us through the goal of using this? I see at the bottom as well, it looks like there's a little area there where you can put in Nazzy's mobile phone number if you need to, and things like that. Essentially, what's the advice on how people will use this pathway?
If I come in there, I think basically the idea was it's a bit of an aid memoir for use when you're a bit worried, you've got that gut feeling there's something wrong in the foot or leg, and that you've got this to hand. So it would walk you through from the top to the bottom through your scenario that you're seeing. You might be any clinician, any lower limb clinician. It's not particularly focused on podiatrists, so they will be a big user. But any lower limb clinician with that new onset severe foot pain or leg ulcer in any clinical setting. And the idea is it will tag into your local COVID-19 protocols. So whatever your screening assessment is prior to seeing patients or bringing them up, you would still use that. And then you would start to think about the two key things that are going to cause limb threat. So immediately want you to think, there are many things you might see in the lower limb that are concerning you in your caseload, but are you seeing limb-threatening infection or sepsis? And are you seeing critical limb ischemia? And that's why we've focused entirely on those two themes, because they're the most likely things separately or together that are going to lead you or your patient towards a terrible disaster if not managed quickly. And then as you go down the pathway, it's just really about managing that scenario. Down the left-hand side with the non-limb threatening box, you then monitor the treatment for that patient locally with GP, nurse, podiatrist. But if, of course, it takes a turn for the worse, because you can have somebody who's got a stable ischemia, for example, or a stable wound, and then week 3, week 4, it goes downhill and goes into that sepsis picture or that critical ischemia picture. So it allows you to sort of, over time, review the patient with those two big red flags firmly in your mind, particularly if you're not that confident with them. And the bottom bit there of the box is literally for local use. So depending on your local availability, you may have an integrated high-risk foot podiatry service or nursing service. You may have a vascular service that's very accessible or remotely accessible, a diabetes foot team, an infectious diseases team, which may be doing home antibiotics, IV, or available via the hospital for advice. And of course, your orthopedic and podiatric surgeons may be playing a big part in your high-risk lower limb picture or not so much. So it's really about you personalizing that pathway to your local environment. What's in the 50 square miles around you? And if you don't know, find out now before you need to use them. That'd be my take on it.
Great. Emma, can I bring you in as our representative of all independent private practitioners watching live and after the fact? Anything you wanted to ask these guys about the sort of logistical, pragmatic sort of application of this, or anything you want to be the voice of, as you so often are brilliantly on the internet? You want to be the voice of the public here while we've got these guys in front of us?
Well, I have to say, I have actually got my printout, and it's version 1.3. So if anybody has got one that isn't 1.3, make sure you go and get the latest one. Martin's been great at sharing that in all the groups and on Twitter and Facebook and everything as well. First of all, can I just say thank you very much to all of you for doing this, and I'm going to use a great Scottish word, a numpty like me. So see, I don't often see a lot of vascular stuff in clinic, but because of changing ways, I might be the emergency person on for the urgent care in my clinic that day. So it's great to have this to refer back to break it down nice and simply for me. I think I've probably asked most of the questions I already had. I've got my little notepad here that I've been writing down things as we went. Not Nazi's phone number, because, you know, I'm married and we might have to get that one offline. But you know, I've had all my little questions going here. But for me personally, I think you've all done a really lovely job of making this nice and simple. And yeah, I feel a bit more confident now if somebody comes into my clinic with presenting about this. I know what I'm supposed to do. The takeaway for me is going to be, how do I find out these phone numbers? Now, I've already had my little tendrils out, and I happen to know somebody that works in my local NHS, and I private messaged them and asked, look, what are you guys doing? Can I get a phone number? And very kindly they did respond with one. But it'll now be a little bit of fact finding for me to find the contact points for my area and how I can take it from there, so that we're ready and hopefully not have to use them, but ready if we are.
Perfect. Great. Craig, anything else that my screen down here is frozen? Any other questions?
No, there's been a lot of comments, and I won't raise any, but there is one question, and I'm quite curious about this one myself, and it's more for Mike and Nasir, but there was something, this is from George, he said there was a comment in the media that COVID can lead to an acute ischemia on its own. Has that been reported, or?
Yeah, I've been asked the question 3 times, Mike. I think this might be one for Mike, because you need somebody intelligent to answer that question.
Yeah, there's been some recent report that the infection was associated with endothelial damage and antiphospholipid antibodies. So I think there were 3 cases where there was evidence of infarcts in the brain, and also of ischemia in the leg. So I think we're only just trying to understand this infection, you know. Originally it seemed to be, oh, it's a bad chest infection with a bit of flu. But it's an horrendous infection. You're getting, and on top of that, you get, I think, a lot of clotting. The FDPs are up, and they're now considering anticoagulating these people right from the beginning, because they may clot in the arterial pathways. And just to add to that, there's been some report in the Italian literature of these bluish purple areas in the fingers and in the toes and on the plantar surfaces in young people who get this COVID infection. It's in the Italian literature. I think it's a small vessel occlusion related to the infection. So I think be aware that this condition can cause much more than a respiratory problem. As well. And I mean, the other clue, if you're screening people, is muscle aching that people get. You know, people say that the muscle enzymes are up in the sky sometimes with these conditions. So I think it can cause lots of different problems to different systems.
Right. Yeah. Thanks, Mike. Right. I think we're just on the hour, so it's probably a good time to wind up. But there's been one question that got asked really early on, and I've decided to hold it to the end. And it's for you, Martin. And I apologise, I can't remember who asked it, but they wanted to know, how were you able to get a haircut in the lockdown?
Well, my 16-year-old daughter, who's marvellous at doing Game of Thrones female hairdos, has managed to learn on me how to do a short back and side. So I'm really quite pleased with the effect.
Not bad, actually.
Yeah. At some point, Nav, I do promise you I'll be joining you this week. Come off when it needs to, but not
yeah. I don't know whether any of you are familiar with what's happening here in Australia, but hairdressers have been deemed as essential workers, so they're still open here in Australia. I suspect that's more to do with the fact that there's 40,000 people unemployed if they do close them down, but they haven't actually been directed to close yet. Look, thanks very much, everyone. Look, it's gone really quickly. We're approaching the hour. So, you know, again, thanks everyone. For those who've joined late, we did have a few technical issues. Hopefully the video will be back on YouTube. Well, the video will be on YouTube in a couple of hours. It will be rendered on Facebook. We might just have to link to it a bit differently than usual. So thanks so much, everyone. It's been really good.
Thanks, guys.
Okay, bye.
Thank you.
Thanks.
Yes, bye.